Welcome to Mary Greeley Primetime Alive presentation, Putting Out the Fire, Prevention and Treatment of Gastroesophageal Reflux Disease. I am Danielle Linder, and I am filling in for Vicki Newell, who is the manager of Primetime Alive. As a reminder, if you would like more information about Primetime Alive or how to join, please visit our website, mgmc.org/PTA. Our presenter today is Dr. Larry Johnston. Dr. Johnston received his Bachelor of Science from Mount Mercy University in Cedar Rapids, his Master of Science and Doctor of Osteopathic Medicine from Oklahoma State University, College of Osteopathic Medicine in Tulsa, Oklahoma. He also completed a residency in internal medicine at Oklahoma State University College of Osteopathic Medicine. Dr. Johnston joined McFarland Clinic's Gastroenterology Department this past August. Please welcome Dr. Johnston.
All right, thanks everyone. Appreciate having me. I've heard good things about Primetime Alive. Like she said, I joined in August, so I'm trying to get used to McFarland and Mary Greeley and things that have happened and maybe things that are getting restarted now, with, of course, of COVID. It's still around and about. But and as she said, I'll be talking about kind of the prevention and treatment of GERD or gastroesophageal reflux disease. I think the battery died. Let's see. There we go. All right, so things we'll kind of talk about today is epidemiology. What that is a fancy kind of Latin term about what the numbers mean. It's like, why is this important? Why am I talking about it with you guys today? Why should you guys take the time out of your busy schedules, me out of my busy schedule, and talk about this? Kind of why it happens or what we think happens and causes symptoms, what those symptoms are, what we do to diagnose this, how we manage it, and kind of what is out there for the future. So first things first, GERD by the numbers. It's one of the most common GI or gastrointestinal disorders. About 18 to 30% of Americans will have symptoms of GERD at least one time per week. Now, studies on that assume that it's a much higher number because there are over-the-counter medications that people take and don't talk about it for their primary care or others, and doesn't get tallied or brought into the data. It's more common in males. We'll talk kind of why we think that is. More common in people over the age of 50. There's been some estimates of over $12 billion is spent each year on the evaluation and treatment of GERD, and some studies show that in the US alone, proton pump inhibitors or PPIs account for over $10 billion in healthcare costs. So the most common treatment for GERD is very expensive when you look at how much it's being prescribed and used by our population. So it's important, it costs money, it's very common symptoms, so we're gonna delve a little more into that. So what is GERD? It's also known as acid reflux. And the American College of Gastroenterology defines it as reflux of gastric contents into the esophagus that results in symptoms or complications. As a little depiction to the side there is we have a complex between the lower end of your esophagus, which is the swallowing tube, the upper fibers of your stomach, and even your diaphragm come together to make a complex that basically keep things that you swallow in your stomach. We do vent or burp, so that relaxes and we have air and things that come up. But sometimes either the contents, the acid, or even food particles can come up in the esophagus, and that can cause worrisome symptoms. We'll kind of go more into that in detail. So what do we think kind of causes reflux or GERD? Some people also refer to it as reflux esophagitis. That is a very distinct term, meaning that you actually see breaks and damage to the esophagus due to reflux. That can only really be diagnosed with an upper scope, and we'll talk more about that as we kind of go through this presentation. So there's kind of two main kind of theories that we think. So the first is that lower complex of the esophagus and stomach is abnormal. Something's happening to it that's causing it to be more relaxed, less tight, not as much tonicity or tension in it, and so you're having more stuff kind of come up through it. Or we're increasing the abdominal pressure, which then is just putting on forces into that thing that just can't keep it tight like it's supposed to. So under that, we have functional. That means we all kind of, like I said, vent or burp or belch and get air that we swallow back up. It's a closed loop system. Everything that goes in your mouth will either come back up and out or it comes out the backside, okay? So we normally do, as we eat, our stomach swells and kind of gets bigger. It's called accommodation. And to do that, we make room on our abdomen, and we also kind of have to get some of that excess air that we don't need to help us break down our food. We get it out. Mechanically, that sphincter can get weaker. There have been foods and drugs that have been known to decrease that tonicity or strength of that lower sphincter. And those are more common as we get older. We take more medications, and some of those medications have side effects like that. And then sometimes as we get older too, is that there's a hiatal hernia. That's where part of your stomach actually goes up into the cavity, up into the chest cavity outside the abdominal cavity. That's usually defined by your diaphragm. And so that will displace that apparatus. So like I said, the bottom of your esophagus, the diaphragm, and your stomach work together to keep that thing closed. The stomach then goes up through the diaphragm, then the whole thing is kind of altered. It makes the structure different. It doesn't work as it's proper. And then we go down to the increased abdominal pressure. Again, as we age, we have a little bit more obesity, and men get it more in their abdomen than more of their hips and their thighs like other people. And then also pregnancy is very common. And that causes increased pressure in there, as well as, again, increased gastric volume. So if you eat big meals, your stomach stretches. Again, that kind of puts more force onto that sphincter. And kind of what that really kind of turns down into is, and why we think it'd be worrisome, why it causes symptoms, is kind of this diagram here. So we'll start kind of that incompetent LES, or lower esophageal sphincter. That's that complex I've been talking about. So when you have that, you get more reflux, so more acid and juices up into the esophagus. That has prolonged activity in the esophagus. It should not be there for long periods of time. The esophagus is not built to handle that, which then can cause breaks in the lining of that, can cause decreased activity, means you don't want to clear it as well, which begets itself the same problems. You get decreased pressure, gets more incompetent, more reflux. The cycle kind of goes round and round and round. So what are the typical symptoms of GERD? So classically, there are two, which is heartburn, which is substernal burning or chest pain, and regurgitation, which is effortless return of gastric contents upwards into the esophagus or even into the mouth. There are other extra esophageal symptoms: hoarseness, chronic throat clearing, chronic cough, maybe sour taste in your mouth, metallic taste in your mouth. Sometimes it can make COPD or asthma worse. So now we'll move into, well, how do we diagnose that? Well, there's no gold standard. Most guidelines, being it from primary care and even gastroenterologists, recommend a trial of a proton pump inhibitor or acid-reducing medicine as a diagnostic test for people that have those classic symptoms, the heartburn and regurgitation. Well, when do we need to do more than just treat you empirically with a PPI? So alarm symptoms or red flags are symptoms that are concerning that need further workup before just starting a medication. So some of them are pain and difficulty with swallowing, loss of appetite or weight when you're not trying, chest pain, and that is definitely something that needs to be considered first and foremost. You need to see your primary care cardiologist more urgently than you would see a GI doctor. If you have persistent vomiting, if you have new abdominal pain that's new or different than you've had before over the age of 60, white males that are over 50 have obesity and have had heartburn for greater than 5 years have increased risk of complications. We'll talk more about those again later. If you have a smoking history, if you have any family history of esophageal or gastric cancer, then you have higher risk of complications from GERD and should be evaluated and talked with the doctor. So, like most things, we don't try to give you medicines first. We try to do lifestyle modifications, diet, other things to help, because you have to eat every day. You don't have to take medications necessarily. So some things that can help with GERD are limiting trigger foods. Common foods that cause heartburn are spicy foods, citric acid foods, tomato-based sauces and tomatoes, coffee, alcohol, carbonated beverages. That includes even water or soda, chocolate, and fried foods. These help GERD about 50%. Okay, so just this alone can increase your GERD symptoms or decrease your GERD symptoms, by about 50%. These are very individualized. Not everybody should not eat everything on this list. That is not an inclusive list that you should not. If you have GERD one time, don't ever eat these foods ever again. That is not true. Okay, don't take that as what I'm saying. But things that you might know, right? You eat a pizza and you get more heartburn, then maybe you got to cut back on your pizza or use moderation, because that might be one of your trigger foods. Other lifestyle modifications include, if you're a smoker, quit. And you probably hear that from your primary care and everybody else, because there's been no data to support tobacco is good for anything in your body except for one kind of disease that I treat, but it's not worth all the side effects. So if you're a smoker, quitting and stopping and being abstinent from it. If you're overweight, then weight reduction does help, as we kind of think the causes of GERD are, again, abdominal fullness and weight cause more pressure. If you have more nighttime symptoms, then avoiding eating before you go to bed for about 3 hours, and also raising the head of your bed about 6 to 8 inches also has been helped with nighttime symptoms. And if you feel like you have more of those belching, burping, and heartburn symptoms after eating more smaller, frequent meals is more helpful than eating, three big meals per day. And if lifestyle modifications and diet don't help, then we do have medications that we can add and use conjunction. Some of those are we'll go through them we go by how we stratify you as how bad your symptoms are. So mild is that you have less than two symptoms per week of heartburn or regurgitation. And those can be managed with over-the-counter antacids, Tums or Maalox. And how that works is it actually just basically neutralizes, like baking soda. It stops the chemical reaction of acid. Short-term relief, it quickly goes away. You likely would need to get treated again if you had continued issues. The other medicines that are just a step up from that are over-the-counter or by prescription, but more common over-the-counter, is a histamine receptor blocker. They are cimetidine and famotidine. Cimetidine is no longer on the market. You might have been aware of that a couple years ago. The people that made the generic form of that unknowingly put nitrates in it, which has been shown to increase bladder and kidney cancer, and so it was taken off the market. We do not know when it will be coming back. So right now, the only one you could find is famotidine if you went to the pharmacy. It comes in 2 flavors, Pepcid and Zantac, but they're basically the same medication. How they work is they block one of the hormones that makes the pumps in your stomach want to make acid. It does it for longer periods of time than antacids, but they are weaker, they are reversible, so that acid production does go back again. And very commonly with chronic use, being over about 2 weeks, you'll lose effect. You can't get tolerant to it. It means that you will make acid above and beyond it. Your body will kind of shift to a different mechanism to keep making acid. So it's not really a long-term kind of medication. So if you have symptoms more than 2 times per week, or you are using Tums more often, or you're using an H2 blocker for longer than 2 weeks and you're now having more symptoms, then it's time to move on to a proton pump inhibitor. Like I told you earlier, it accounts for upwards of about $10 billion worth of medical costs in a year. So these medicines are very, very common, both over-the-counter and for prescription. They are currently the most effective medication to reduce acid. They are a special kind of medicine that needs food, being it that it needs to be broken down in your stomach with acids. You need to eat after you take it, as well as it works on actively secreting acid pumps in your stomach. So to be effective, you need to have those pumps working, and those happen when you eat. So you should take this medicine 30 to 60 minutes before you eat anything. That commonly doesn't get discussed by your primary care, by pharmacists. I see a lot of people that are taking them inappropriately. We get them on the right dose at the right time, and their symptoms go completely away. So taking the medication right is very important. It does take about 3 to 5 days to get to steady state. So if you have heartburn right now because of that pizza you ate, it will not work. It will take time to finally build up in your body, to cut down the acid, to finally get to the point where you will have improvement in your heartburn. So these medicines take about 3 to 5 days. You kind of wait it out. You can take them with other medications as we're getting that up to the right state, okay? These medicines are broken down by this special enzyme in our body that kind of detoxifies a lot of different things. It's called this CYP2C19. It's the most varied in the human race. So there are some of us out there that I can't tell you who, because we have no tests to look for this enzyme. It's not cost effective, but there are some people that are fast acetylators, which means that you break down this medicine faster than other people. So you might need a bigger or heavier dose to get the same response than somebody else because of that enzyme in your body. All these medicines go through that enzyme, So there is a little bit of a trial and error just because I don't have a test to kind of preventively know which medicine would be best for you based on that. Two is, okay, that's next slide. So here's the kind of list of all the medicines that are currently approved in the United States for the treatment of GERD. Again, the H2 blockers are the weaker ones that are on the top, and most commonly is famotidine. Cimetidine has been taken off the market. Nitazidine is not as commonly found. And those are the PPIs. Kind of standard doses are listed, and then prescription doses, of course, are that kind of standard dose or even higher than that. So PPIs are not equal, being it that they do not all get your acid suppressed as well as others. There are other medicines that we use, and I'm going to use an analogy to narcotics. So how you think about narcotics, or how we in medicine think about narcotics, is morphine is given an equivalent of 1, and we have drugs that are stronger, so 4x stronger than morphine, 10x stronger than morphine, and we have some that are weaker than morphine. In the PPI world, we use omeprazole or Prilosec. It's the 1, and we have some drugs that are, if you have a lower dose, it's stronger. We have some that are weaker. So one of the weakest medicines for PPIs is a pantoprazole or Protonix. But it is also one of the most prescribed medicines that I've seen. So if you fail that medicine, I change people quite commonly just to stronger medicines, and they get better control alone. So, to leave that with you is not all PPIs are the same, okay? You can't take one dose and think it's the same as other things. They have a hierarchy. And omeprazole is going to be the middle of the line. We have some stronger, we have some weaker. Like I said, PPI is the most prescribed medicine for GERD. It's the best medicine available currently in the United States. Well, let's kind of look at what it's really good at and what it's not so good at. So healing damage to the esophagus due to GERD, it is very good at. That's that green bar, and you can see it's close to about 95% if you take it correctly. If you have severe GERD, it's a little bit less because likely you have mechanical problems or something else that's continuing to have severe GERD. Heartburn relief in and of itself without esophagitis, or what we call GERD, is close to 75%. NERD, which is non-erosive reflux, is a little bit worse, but still pretty good, of over 50%. If you have regurgitation, it's less than 50%. That again kind of leads more to a mechanical problem, that valve is just not staying closed and that stuff is coming back up into your esophagus. It might need other therapies. Chest pain, if it's pH related, being that you have active exposure to your esophagus, then yes, it's good. If it's not, then it's likely related to something else, and so PPIs are not as helpful. And again, those extra esophageal symptoms I kind of talked about earlier, PPIs aren't the best. As you see, just taking the medicine or placebo, that blue bar for hoarseness is about equal to what it is with on the medicine, and chronic cough is maybe a little bit better. So I've talked about PPIs for the past probably 10 minutes, but we probably have all heard, or you guys have seen in the news or in journals, that PPIs have gotten a lot of things that say, hey, don't take this medicine long term. It can cause dementia. If you have heart disease, it can cause you to die early. It can cause chronic kidney disease. It can cause bone loss. It can cause infections. Well, we're going to talk about that for the next probably 10 or 20 minutes, because this is something we need to kind of delve into and see if this really matters. Okay. So yes, PPIs have been associated or been in the literature talked about increased risks of infections, pneumonia, cancer, specifically gastric cancer after you're treated for a bacterial infection in your stomach called H. pylori. There has been some evidence of mineral loss on B12, magnesium, calcium, and iron. There's some theoretical effects on drugs of methotrexate and clopidogrel or Plavix. And then, of course, like I said, chronic kidney disease, heart attack, strokes, dementia, and death. Well, those are all not true. And why that is how they got that data is from retrospective observational studies. And we're going to talk about those are. So those are where you take a population of patients, let's say you guys, and I have a theory that I think you guys have something in common. I look at your charts or through a database, through insurance claims, and I say, oh, yep, I see that stroke is common in this population. Well, what do they have in common? They look through their med list. What medicine's commonly on people's med list? PPI medicines, right? $10 billion is spent on those medicines. They're commonly on there. And they go, oh, if we look and we compare people that are not taking PPIs versus if they are, do they have an increased risk in that stroke? And they have data that says anywhere from 50 to 60%. But if you look at what's called the absolute relative risk of that individual person having that because of that medicine alone is closer to about 0.2% or 0.5%, which is much different than 50 to 60%, correct? So these studies are based on codes that get put into the computer, computers that are in the chart, databases. Well, those codes are only, sometimes they're there not with all the detail that they should have. Two is we don't know if people are taking that dose of that PPI, how long they've been on it, are they compliant, are they taking it like they're supposed to, 30 to 60 minutes before they eat? Are they taking the PPI for the right reasons? And then, of course, the biggest thing is causation and association. So causation means that this makes this happen. Association means this happened, these are the things that may have contributed to it. That is completely different than one and one, right? So association does not prove causation. And commonly, PPIs are people that are a little bit sicker and a little bit older, and that complicates things because, again, if you have stroke risks or if you have strokes, odds are you are a little bit sicker, have other things that are comorbidities that increase those risks alone, not just that medication. Okay. So what the GI Society say about PPIs are that if you are need it long-term, then you should not be on any probiotics to prevent infections. You shouldn't have to increase any calcium, magnesium, B12, iron above your daily allowance or recommended daily allowance. You should not have to have any screening for bone mineral density, your serum creatinine, looking at your kidney function, calcium, magnesium, or B12, unless you need it for other reasons, not just because you're on that medicine. And really, like I talked about earlier, there's not a specific PPI formulation. We shouldn't talk about an individual drug, the dose of that drug, based on the potential risks, okay? Another GI Society says this, which is a very long statement. I don't expect you to read it, but it's in your handout, so that's good. But it basically says the same thing of that PPIs are the most effective medical treatment for GERD, even though there has been some studies that talked about the things I talked about. They were not the best studies when vetted by doctors and other analysis have basically disproven those things. And we have not established a cause and effect between PPIs and adverse conditions. So the most kind of important statement is that very last line. So for the treatment of GERD, GI doctors agree that its well-established benefit of PPIs far outweigh any theoretical risks of complications. Okay. With that being said, it does not mean that you should be on a PPI forever, just like any other medicines that you're on, right? You should be on them for the indications that are appropriate. You should be on the dose that is effective for your treatment, but also we should need to de-escalate that therapy if we need to. These medicines are very common to be left on people's med list for eternity. Because if someone said you had GERD at heartburn one time and gave you a medicine, I don't know that, if I got 10 doctors in here, I don't know if 10 doctors would tell you to stop that medicine. Because like, oh, you needed it, you need it. But there are indications to be on it long term, okay? And that's that kind of blue box in the top top right. So that's if you have Barrett's esophagus, which we'll talk a little bit more about, but that is actually changes in your esophagus that is a precancerous process where that reflux is so bad that your esophagus is trying to protect your body and turns it more into like gastric-like lining. If you take non-steroidal anti-inflammatories, so ibuprofen, Motrin, Aleve, naproxen, naproxen, Mobic, meloxicam, diclofenac, the tablets, and you use it long-term and you're over the age of 65, you have an increased risk of bleeding with those medications, and you should be on some form of an acid reducer with them. If you've had severe esophagitis previously on endoscopy, you will likely need that for the rest of your life. We know that if you ever have class C or D, which is severe, and we stop that medicine, it is likely to come back in 6 to 8 weeks. If you've previously had a GI ulcer or a stomach ulcer or a small bowel ulcer and it's been documented, then the same reason you have increased risk of having those reoccur, and you should be on medicine basically to control that symptoms and reduce that from happening again. And so you continue it, and then you would talk with a GI doctor about how long or what else I can do to stop it if we really needed to. Now, if you look at these other boxes, which are the most common things, that you've had GERD yourself, you've taken medicines over the counter, your primary care gave you some medicine, you really need it for about 4 to 6 weeks, and then we got to reassess, because you could have been eating something in that time, could have been other things that are related that increased your level of GERD during those times. And is it better now? And do we need it at a lower dose, or do we need it can we go down to a different medicine that's more per occurrence than long term? And then the middle category is a little bit different. It's a little bit kind of in between. So that means that you've had peptic ulcer disease, again, from NSAIDs or H. pylori. Those are ulcers sometime. If you've had a H. pylori infection, you need to be on it. And then if afterwards you can come off. And then we also use it for stress prophylaxis in people that are severely ill in the hospital. So they need it when they're there, they just don't need it when they go home, okay? So this is something that we, GI doctors or your primary care, should help you with, talking about, again, why do you need this medication, what's the indication, and is there anything we can do about the dose? Do you need to be on that dose, or is there a less dose? Is that better for you? Okay. Well, just like any kind of disease, not always do we control your symptoms with just what I've talked about. So sometimes you got to go up from one stage to the next. You got to do Tums and Maalox, but then that doesn't work, and we go to the next step to the next step. So what happens if you're on a PPI and you're continuing to have symptoms? What do we do next? So like I've talked about, not all PPIs are equal. So sometimes you got to change the drug to a different medication from one PPI to another. Sometimes we got to add on other medications on top of the one you're on. Change the dose. Sometimes you process that medicine faster, like I said, because of that enzyme. You might need to take it twice a day to give you better coverage, or you maybe shift it to bedtime because you get more symptoms at bedtime. Or do we need to do other things to work it up to find out if that's really truly the diagnosis? So if you're having continued symptoms, well, maybe that's the wrong diagnosis. Maybe this isn't GERD, maybe it's something else. And of course, there are surgical treatments for GERD. I won't get into it because I'm not a surgeon, but we do send some people to surgery for certain things that are related to GERD. Usually it's really very refractory with other kind of symptoms that are severe, and we'll kind of talk about those here in a second. So what kind of further testing do we do to help us kind of refute or confirm the diagnosis of GERD? So one of the most common is an upper endoscopy. That's done by a gastroenterologist, or some general surgeons do these procedures. That's a esophagogastroduodenoscopy, fancy thing of saying I look at your esophagus, stomach, and the first part of your small bowel. That's done with a flexible scope, the light and a camera. That kind of image there shows that under anesthesia, take that scope and we look through your esophagus, into your stomach, and then down into your small bowel. It's diagnostic and therapeutic, being it that if we see anything that's abnormal, we can take biopsies. If there's strictures or other things we have to do, we can dilate and do other things. Other tests are a barium swallow. This is less invasive, obviously. You're not having a tube put into your esophagus. It's just you drinking contrast and taking x-rays. It can see if there's any narrowing or changes to the esophagus or the swallow tube, as well as they wait a little bit and they can see if there's stuff that refluxes back into the esophagus. So they take multiple x-rays. And the other one is called esophageal manometry. What this is a catheter-based test that evaluates the swallow. So it's a tube that goes in through the nose, down into the stomach, has pressure sensors in the esophagus. We give you little water, sips of water, and then we watch it squeeze, the esophagus kind of squeeze and operate. And sometimes there are other reasons why you have GERD is because the esophagus is not working well. And that's how that's diagnosed. Well, what happens if you don't have GERD? It's not controlled, all right? So you're on PPI and things aren't getting better. Is there stuff you should be worried about? Well, good news is most people, a vast majority, like 70 to 75% of people don't develop severe complications. Those severe complications are kind of things I've kind of mentioned, but I'll show you some pictures and we'll talk a little more about. So first and most common is reflux or erosive esophagitis. So we have a normal esophagus, that nice pale pink lining, and then you see the erosions, which is that redness, right? Just kind of like you hit your thumb with a hammer and it's all red and swollen and angry. That's erosive esophagitis. And then the picture to the far right is called Barrett's esophagus. That CE is labeling stomach lining or cardiac mucosa. So that's where there has been changes to the esophagus to protect against the acid. Your stomach has lining that protects you against your own acid. We are what we eat. The esophagus, however, doesn't have that same protective barrier, but it does. It will change itself. It will try to protect itself if it has recurrent injury with acid reflux. And that can happen. That's called Barrett's esophagus. That is a precancerous, means it's a step down the pathway to esophageal cancer. Other things that can happen are strictures. So that A shows that narrowing. So that injury, how your body heals that esophagitis, is kind of two forms. It can either go into Barrett's esophagus or it can lay down scar tissue. Just like when you skin your knee, if it's really deep enough, you might get a scar there. Well, that happens in the esophagus sometimes too. The rest of those pictures are showing one way that we can actually stretch that open to help swallow better, help get things better. Other problems are, again, esophageal cancer, dental problems like dental caries or cavities, and then there are some kind of chronic throat and lung problems that have been associated with severe GERD as well. So what's the future? We talked about PPIs. They've been around for almost 30 years since the first one's been approved, especially with all the data or associations that have been tried to be put on PPIs. The future are these new medicines called a new class of medication, kind of a new mechanism of action. It's called potassium competitive acid blockers. They are currently not approved in the United States, but there are clinical trials going on to get it approved by the FDA. How they differ from PPIs are that they reversibly and ionically, which means they are better absorbed by your body and better control of what they're supposed to do compared to a PPI. So that means they are faster on, and they also last longer, and they prolong acid suppression. Another thing is they are independent to that enzyme I talked about. So we can say you take this medicine and we will all get the same response versus people that have different versions of that detoxifying enzyme. Okay. So it's currently approved in Japan and in Asia, and how they got it approved were this study here. So this compares vanoprazin, which is a potassium acid competitive blocker, like I just showed you, comparing that to lamproprazole, which is the brand name of Prevacid here in America. So equal doses of that medicine, looking at the response to erosive esophagitis. So on the left there, you see all patients that had esophagitis. At 2 weeks, that vanoprazole was about a 91% reduction in that esophagitis compared to 82%. And at 8 weeks, it jumped up to over 99% versus 96%. And then when you looked at people with severe, which is, we call that Los Angeles grade C or D, which basically means severe esophagitis, it was 88% to 64 at week 2 and 99 to 88 at week 8. So you can see it does really help in those people that have severe reflux. So take-home points from this talk would be lifestyle modifications are very effective. So those were the trigger foods: stop smoking, don't eat late at night, don't eat big meals, cut down on alcohol, and lift the head of your bed about 6 to 8 inches. So those are things that you can try. PPIs are safe and effective, even though they get a bad rap in some studies, but those studies have been disproven with better data. If you have refractory symptoms or those red flag symptoms, I would recommend you seeing me or one of my partners. Again, things I wanted to kind of cover for you guys as you meet this population more than, say, younger patients, is that, again, if you're on a long-term anti-steroidal, being it Aleve, Mobic, naproxen, naproxen, Voltaren, or diclofenac, if you're taking that long-term for aches and pains or osteoarthritis or other indications, you do have an increased risk of bleeding if you are over the age of 65, and you should be on a low dose of a PPI to reduce that risk. That also goes with if you are on antiplatelets. So you had a recent heart stent and you're on 2 medicines to help with that. You should be on that when you're on those medications, as well as if you take an antiplatelet and an anticoagulant. So if you're on aspirin or Plavix on top with Coumadin, Eliquis and Xarelto, I'll talk about, so rivaroxaban and apixaban, then you should, over the 65, again, increased risk of bleeding, and you should protect your upper GI tracts. That's the most common place to have bleeding, okay? So a low dose of a PPI. And the one that doesn't get really brought up from primary cares as much, we do have screening guidelines, meaning that my GI societies recommend patients, male patients over the age of 50 with obesity and have had heartburn for more than 5 years, you should at one time have an EGD to rule out Barrett's esophagus, equivocal to how you get colon cancer screening for average risk, but you are an increased risk of that complication, and it should be done, okay? Questions?
Okay. If you have a question, please raise your hand and I'll bring the microphone to you.
You have one question online. Is there any value in taking a PPI every other day or every third day instead of every day after having taken it every day for up to 14 days? Also, is it better to drink decaffeinated coffee?
That's a good question. So, yes, I didn't really get into that. I didn't really talk about, I should have probably mentioned that during that de-prescribing slide. But when you suppress your acid with a PPI medicine, you do it effectively. If you've taken it longer than 2 weeks, you are very high likely to get what's called rebound reflux. And why that is we, with that medicine, are stopping a normal cycle of hormones in your body. And every time we put a brake on it, things build up upstream. Well, that hormone will make you make more acid than you've ever made in your life once you stop and pull that away. So yes, the best thing to do to come off these medicines, if you've been on them routinely, is to take them kind of every couple of days, back off to every third day over a week, and then finally stop them. That is correct. Coffee, no. It doesn't matter if it's decaffeinated or caffeinated. It kind of depends on what your trigger is. Most people feel it's coffee in general and not if it's caffeinated or decaffeinated, but you could try either one and see if that affects you individually.
You mentioned foods that trigger GERD.
Yeah.
Are there foods that neutralize the stomach acid that would be beneficial?
So there are. Those are more dairy-based products, right? So yogurts, milks, things like that. There has been some more natural treatments that you might look into. Aloe, apple cider vinegar has also been shown. Obviously, I can't give you big data to say that's the best thing for you, but there are the more natural things that can kind of help do that as well. Mm-hmm.
I have been prescribed to take omeprazole twice a day, morning and evening. Mm-hmm. Nothing was said about before a meal. So am I worthless?
No, you are not. That is not your fault. That's on us, because that's how that medicine got approved to be taken, right? Like, it should be in the insert like you take some antibiotics with food, right? There are certain medicines you're supposed to take with food. That's because your body needs that acid to make that drug be effective in your body. So that's not your fault. That's our fault. And I say that as medicine, including pharmacists and others, are educating you on that.
Yeah, but does that mean I should be changing if I should be taking it before a meal? I mean, I'm not at nighttime. Take it before bed. I don't eat then.
Yeah, no. So that's why I tell people you got to take. You don't have to have a big meal. It's not supper time. You don't eat 1,000 calories. You got to eat something. So I would move it earlier and just eat something. Yep. Yep. You got to eat 30 to 60 minutes after you take the medicine. So that's more specific. That's better timing than I don't care what time of the day you take it, just as long as you eat something shortly afterwards. Yeah.
Okay. Another question down here? No? Any more questions online, Tim?
Nope.
Okay. Well, thank you, Dr. Johnston, for joining us today for this Primetime Alive presentation.
Thanks, guys. Appreciate it.
Thank you.
You're welcome.
Again, thank you, Dr. Johnston, for your time in preparing and presenting this program for us today. Our upcoming programs are The Importance of Posture with Aging, Wednesday, March 1st at 2 p.m. And the next program after that will be Staying Independent and Knowing Your Options, Thursday, March 9th at 2 p.m. So we hope you'll join us, and thank you so much for coming today.